So I'm just gonna go based off the study guide. I just filled in for you guys. Your professor did fill out some, but I just added some pictures and some extra information. So we're just gonna go over it. So starting off with postpartum hemorrhage, we did go over this. I believe that was 2 weeks ago. So we've talked about this before. So all postpartum hemorrhage is excessive bleeding following childbirth. So when a woman, after she delivers a baby vaginally, the maximum amount that she should be putting out of blood after is 500 milliliters. If she had a C-section, the maximum amount of blood she needs to be putting out is 1,000 milliliters. If it's anything more than that, that is a problem and that is not normal. That is a sign of postpartum hemorrhage. And that is when we're going to be alarmed and we're going to be looking for what could possibly be causing this postpartum hemorrhage. So, risk factors, uterine atony. That's when the uterus fails to contract after the woman gives birth. We know that after a woman gives birth, we need that uterus to continue contracting so that the woman doesn't keep bleeding from the site where that placenta was. So we really do want that woman to contract after she gives birth. So another one is a retained placenta. So after a woman delivers the baby, she also needs to deliver that placenta. But if some pieces of the placenta remain in there, that also is a risk factor for postpartum hemorrhage. All right. Also, prolonged labor as well, multiple gestation, because she had so many babies, maybe two or three. Um, and sorry. She had like two or three babies that she just, delivered. It's gonna take a while for that uterus to go back down to the size that it should be. So it's gonna take a bit longer. Also high parity. So how many children has this woman had before? Has she given birth 4 other times? The more children you have, the higher risk you are for a postpartum hemorrhage. Especially, I'm not talking like if you had like two or three kids. I'm talking like if you had like 4, 5, 6, 7, like you're at higher risk for postpartum hemorrhage. If you had many kids previously. Um, Clinical manifestations, heavy lochia. So that is the output over here. So if it looks like this bottom one where she's saturating that pad in like a minute or 2 minutes, that's not normal. That's a sign of postpartum hemorrhage. Especially if it's bright, bright red as well, that's not normal. Like rubra, red, bright red, and heavy, saturating that pad. Um, Also, a boggy uterus is not normal as well. It's supposed to be firm, right? We discussed this firm and midline and at the umbilicus following birth. Okay, that's where we want it. Okay, and that's how we want it to feel. Tachycardia also and hypotension. Those vital signs are very important when we're talking about someone who's losing a lot of blood. Whenever someone goes into hypovolemia, they will have tachycardia because that heart, is trying to compensate for everything, for the lack of blood. Hypotension because we're losing blood. Whenever we lose something, lose fluid from the body, hypotension is what happens. Tachycardia is our body trying to compensate, be like, okay, like let me beat a bit harder so that blood can start pumping to the organs and I can have more blood flowing around. So our body just tries to compensate with the tachycardia. Pallor, they're gonna look very pale, all right, very white in the face. Means that's what happens when you lose a lot of fluid and blood within the body, right? Lightheadedness as well. So these manifestations, they're pretty self-explanatory. Next up are interventions. Our first action. So, okay, so first thing, postpartum hemorrhage. We see that this woman's bleeding unnormally, right? It's not normal. She's bleeding more than that 500 ml, more than that 1,000 ml if it's a C-section. First thing we're going to do, we're going to be like, what's the cause of this? Because there's so many different things that it could be. So the first thing we're going to do, we're going to look at the uterus, right? We're going to see, is it boggy? If it's boggy, then what are we going to want to do? fundal massage to promote uterine contraction. Nurses do this, okay? This is up to you. You're gonna notice it right away. You're gonna do a fundal massage, and basically what you're doing with the fundal massage, you're basically like hinting to the uterus you're okay, like come on, you need to contract now. So you doing that is stimulating the uterus to be like, oh okay, like I need to continue doing this. Okay. Administer oxytocin, pitocin, IV or IM, followed by misoprostol or coboprost if needed. But oxytocin is that main one. Oxytocin is what stimulates contractions. So oxytocin is a natural hormone within the body. Us as women, we do have it within our body. When we breastfeed, that hormone is actually stimulated. So when women are actually breastfeeding, they sometimes feel contractions because that oxytocin is being released. When a woman breastfeeds, oxytocin gets released and that causes contractions. So we tell a woman, maybe they tell us they're breastfeeding their baby who's 1 day old and they're like, oh, I'm feeling contractions. We'll just tell them it's normal. You are breastfeeding, that releases oxytocin, which causes contractions. So we would just educate the woman on that. But yes, oxytocin is the first medication you're going to want to give if the underlying cause is uterine atony. Okay. Misoprostol and carboprostol are also medications that, like, this one like ripens the cervix, things like that, causes a bit contractions. But the main one we're looking at is oxytocin. IV or IM, okay? Monitor vital signs and assess for signs of hypovolemic shock, right? What did we say? Tachycardia and hypotension are the vital signs, right? And we're going to assess for signs of hypovolemic shock, okay? And what are signs of hypovolemic shock? These, right? These guys, okay? Ensure that the bladder is empty to prevent uterine displacement. Like we've said 2 weeks ago, if the woman has a full bladder, that's going to displace the uterus. It's going to move to the left, it's going to move to the right, and that's not good. We never want that to happen. All right. Because it can cause a lot of complications, which we'll talk about a bit later. All right, here's some pictures for you guys. So this is a picture of a uterus that is contracting. You see there's no bleeding or anything, it's contracting. You can see that it's like nice and like thick, so you can tell that it's contracting. Here, uterine atony is coming, the uterus is not contracting at all whatsoever. There's no constriction happening, there's only dilation happening. So if there's only dilation happening, what do you think is going to happen? Blood is just going to keep flowing and flowing out of the vagina. All right, so that is the sign of postpartum hemorrhage. All right, here is lochia. This is a saturated pad, which we never want, okay? That's a saturated pad, which we never want. Say she has saturating that pad in like a minute, a 2 minute, an hour. That's not normal. If a woman has just given birth and she's saturated that pad in the first hour, that's normal because she just gave birth. But if she's saturating that pad 6 hours after labor, after giving birth, that's not normal. Okay. So that's your bright red lochia. Zoom out. This is your fundal massage. Okay. One hand under the belly, one hand up here, massaging at the sorry. I completely like misread the image. This is the woman's vagina is down here. This is her belly. So hand goes here, massage. You're massaging up at the fundus, which is up here. Okay. Say that this isn't working, you're gonna have to contact that doctor immediately, right? Because this is very serious, very life-threatening. So basically, that doctor can actually come and like go put their hand like a fist into the vagina, and then have another hand at the top of the fundus, and basically just like forcing that uterus, hey, come on, constrict, and things like that. And it's basically just forcing that uterus to constrict, as you can see. But yeah, first line, this, if the underlying cause is uterine atony. Okay, if the underlying cause is like a hematoma, different interventions. But in here, these things that your professor listed is a interventions for uterine atony. Okay. Moving on. uterine inversion, which we talked a bit about 2 weeks ago as well. So it's basically when the uterus turns inside out, often due to excessive traction on the umbilical cord. All right, you never want to pull on an umbilical cord. All right, that's not good. Clinical manifestations: profuse vaginal bleeding, absence of uterine fundus on palpation, severe pain, because that uterus has literally inverted. Of course, that patient's going to be in pain, and of course, you're not going to feel that fundus, and of course, you're going to see vaginal bleeding. It's trauma. Some trauma has happened to that uterus, all right? Interventions: your priority is to call for immediate assistance. We need that doctor to come down here. Do not pull on umbilical cord if placenta is undelivered. You're not going to want to like pull hard. Sometimes like I've seen like a doctor like slightly like tug at it, not like tug, but like pull a little bit, and then that placenta just came out like freely on its own, but don't tug and pull. All right. Provider will manually replace the uterus. Okay. Administer tocolytics like terbutaline before replacement if needed. Okay. All right, moving on to vulvar hematoma. This is just another word for a perineal hematoma, which we did talk about 2 weeks ago. So this is just a collection of blood in the perineal area, which is usually caused by birth trauma. So like there's like a pressure, like the babies when they come through that birth canal, they sort of put pressure on a blood vessel, and that blood vessel can like rupture, and then all that blood like leaks out of that blood vessel, and then a hematoma forms as a result of that. So risk factors can include forceps, vacuum, prolonged second stage of labor where that baby is just sitting on top like of a vessel, and that vessel ends up popping, and also a large infant as well. All right, same thing. If that baby puts too much pressure on a vessel pops, blood accumulates and forms this. Clinical manifestations: severe perineal pain. This looks so painful, right? Unilateral swelling. As you can see, unilateral, which just means on one side. Difficulty sitting. Of course, this is me difficult sitting on. It looks extremely painful. Interventions: apply ice packs to reduce swelling. All right. Monitor for increasing size or signs of infection. Large or expanding hematomas may require surgical drainage. So, like what we talked about before, the doctor's going to come in, they're going to evaluate that hematoma. If it's like small enough, sometimes they can just like go away on its own. But if it's really large, like this one's pretty big, they might have to go in and like excise it, get the blood out, things like that. So, it just does depend if they're going to drain it, just depends on how big it is. Moving on, uterine involution and fundal assessment. So we did cover this 2 weeks ago as well. So this is part of a review for you guys. Uterine involution, it just means that, this uterus has been growing for the past 9 months. The woman has just given birth. And what do we want now to happen to the uterus? We want the uterus to go back down to the pear size shape like normal, because normally our uterus is the size of a pear. We want it to go down to that size now. All right. We want it to go back to its pre-pregnancy size, that size of a pear, right? So we want uterine involution to happen. Don't get the word involution mixed up with inversion, okay? It's involution is what we want. Inversion, no, we don't want that. All right, so assessment, we've covered this many times. How do we want the fundus? We want it firm, we want it midline, and we want it and at or below the umbilicus postpartum. So right after a woman gives birth, that fundus is going to be at the umbilicus, and then it goes down 1 centimeter per day, each day after after giving birth. So it should be down within like a week or two, depending. A boggy displaced fundus may indicate bladder distension or uterine atony. Okay. So that's why we tell those women to empty their bladder. We never want a full bladder, because if it's full, it can cause a boggy displaced fundus, which can cause postpartum hemorrhage. All right, so we really do need to tell those women to empty their bladder, all things like that. So encourage frequent voiding to prevent uterine displacement. So what I just said. Expected findings. Fundal height decreases 1 centimeter per day postpartum. By day 10 to 14 postpartum, the uterus is no longer palpable abdominally. All right, so everything I just covered. Here's your picture, just to show you guys. This is your umbilicus. This is day of birth after she gives birth to the baby. This is day of birth with the baby, and then immediately after birth, we want it below. Depends. It could be a bit over here, it could be over here, but we want it like at the umbilicus or under, okay? Like the textbook says. Here is a picture of the bladder being full, and that this is not good because look how full this bladder is, and look how it is basically making that uterus shift to the right. And that can cause a boggy uterus. All right, that's not even midline. All right. And this just walks you through it as well. Here's your umbilicus. And it just walks you through that. And alrighty. And you see uterus spaced by full bladder. It's over here. All right. Retained placenta. Like I said, retained placenta is also something that can cause postpartum hemorrhage. So a retained placenta occurs when fragments of the placenta remain in the uterus beyond 30 minutes after delivery. So right after that baby comes out, the doctor is going to want to get that placenta out relatively quickly as well, preventing complete uterine contraction and increasing the risk of postpartum hemorrhage. So yeah, you never want a piece of the placenta staying in the uterus. So that's why sometimes we say that a postpartum hemorrhage, the patient can see signs like hours after delivery, or they can see it days after delivery when they're at home, where that placenta has stayed in their uterus. Now they're at home and now they're experiencing postpartum hemorrhage. If that placenta is being retained in there. Signs and symptoms: prolonged excessive vaginal bleeding. So like we said, up here too, on the first page, risk factor for postpartum hemorrhage, retained placenta. So that is a risk for that. So we know that the biggest sign and symptom of postpartum hemorrhage is that peripad being saturated with bright red lochia. Okay. And then also that boggy uterus, uterine atony. Uterine atony is what? It's when that uterus fails to contract. We need that uterus to continue contracting after that woman gives birth. If not, uterine atony is happening where the uterus isn't contracting and now blood is just flowing and flowing and flowing, and that woman is hemorrhaging. Also, large blood clots or tissue passage. She's basically passing that placenta on her own. Severe cramping or abdominal pain, foul smelling lochia if infection develops. Elevated temperature and tachycardia if infection is present. Okay. If retained placenta is suspected, ultrasound may be used for confirmation and manual extraction, where they're gonna have that doctors have to get that out. A DNC is a dilation and curettage, which basically they're gonna dilate the cervix. Doctor's gonna go up there and they're basically just gonna scrape out the placenta. This is also something that they use for when a woman wants an abortion, where they'll dilate the cervix, they'll go up there, and they'll basically just, scrape out the fetus. Also medications as well. Oxytocin is your main one, like I said earlier. Oxytocin is what causes contractions. It's a normal and natural hormone that we have within our body, but it's also given to patients. All right, and all it does is just it causes contractions. Misoprostol as well. This is called a ripening agent, where they call it too. So this also just like opens cervix as well, which can help, right? We want dilation to happen so that we can get that retained placenta out. So this is called cervical ripening agent. All right. Newborn adaptation and thermoregulation. This is also big in peds. I was tested more on this like with the ped side, but I guess your professor's putting this on it. But vital signs, normal heart rate. Your professor put 130 to 160. Believe like other places say 140 to 160, but just go with what your professor's saying. Respiratory rate, yeah, everyone says 30 to 60. Temperature, 97.7, 99.5. So it's sort of like ours. So it's just like basically not too out of the ordinary. Um, but basically, you want to think about it like so with newborns, they're gonna have like pretty high heart rate and respiratory rate. Like that's really high. That's not normal for an adult. So it's gonna be very high, and then it's eventually gonna even out as they age. All right. Heat loss mechanisms. Cold stress hypothermia in a newborn can be lethal, even in a healthy full-term newborn. Hypothermia can cause a lot of like life-threatening complications in a newborn. So that's why if you're a labor and delivery nurse, you need to, even a mother baby nurse, you need to incorporate like not that baby losing any heat from their body. It can cause that respiratory rate to increase. It can just cause a lot of things, which we'll go into. Rapid heat loss occurs by evaporation, convection, and radiation. So evaporation is the most common one. So it's basically air drying of the skin that results in cooling. So you lose heat because the body is wet. So you want to think that, okay, so this baby has been in this warm fluid for 9 months. That amniotic fluid is warm. It's cozy for them. They just want to stay in it because it's nice warm temperature. Now they're being delivered and now they're in the world where it's super cold compared to where they were just at in the mom's uterus, where it was warmer in there. So that baby is wet. They're covered in amniotic fluid. Now it's colder out in the real world. What are you going to want to do? You're going to want to dry that baby, right? They're going to be wet. If you're not going to dry that baby, they're going to lose heat really fast from their body. So basically, this one, you're just losing heat because the body is wet. So it's insensible water loss from the skin and respiratory tract, which increases loss via evaporation. Also, if you're putting wet linens or clothes on that child, you want to dry that baby, put dry clothes on that baby too. Make sure that baby is dry before you're putting clothes on that baby. Um, Also during bathing. So if you're a mother baby nurse, make sure that baby is completely dry before you put clothes on them. All right. So the main prevention is drying that infant and then putting some dry clothes on them, hat on the head, all things like that. Conduction is when you use warm blankets and skin-to-skin contact. So this is movement of heat away from the body when newborns come into direct contact with objects cooler than the skin. So you can see here, this baby's heat is going to the object it's on. All right, so if you're putting a stethoscope on that baby, that stethoscope is cold. So sometimes you're gonna have to warm it up because that all their heat can go to the stethoscope. Also your hands, warm up your hands. If you're putting that baby on a scale, they do in the like mother baby unit have scales that are warmers. So like this one here, they have these where that is actually warm. So that baby is not going to be losing too much heat. All right. So right when that baby is born, we dry them off and we're right away going to want to put them on mom because that helps bonding. Most people say like people who are not nurses want to say that they put skin to skin for bonding, but honestly the main reason that nurses will say is so that baby doesn't lose heat, because if a baby loses heat, that baby is at risk for a lot of life threatening things that we're going to discuss. All right, so skin to skin contact, you want to put that baby on their warm mom's chest. That mom's chest is going to be warm, so put skin to skin with mom. Warmed blankets as well. So cold blanket, heat from them will warm up blanket. So put warm blankets on the baby. Radiant warmer, which is this. And then warm your stethoscope and hands before touching newborn. So all things like that. Whatever you're going to put that baby on, make sure it's warm. You don't want to put a baby on a cold scale or put a cold stethoscope on that baby. And that's all conduction is. All right. Radiation is basically transfer of heat to cooler objects, not in direct contact with the newborn. So here, this was in direct contact with the newborn. This is not in direct contact with the newborn. And what I mean by that is, so if anyone's becoming like a new mother or anything, we usually would teach them uh, to not put the crib like under a window, like a cold window. Um, you want to put the crib somewhere that's not near a window because this baby's not in direct contact with it, but near it. So do not place cribs near cold windows or outside walls. This actually was a NCLEX question. Keep cold equipment away from neonate and do not place baby near anything cold. So anything like that. So the main thing is like do not place a baby near a window, especially their cribs. And you want to educate like new mothers on that as well. Convection. Avoid drafts and cold air exposure. So transfer of heat to the air surrounding the newborn. So basically, prevention, warm, draft-free environment. So if you're keeping that door open and there's a draft in it, or that a window's open within the unit, and that air is just like coming within the room where the newborn is, that can take heat away from the baby because the baby's heat is going along with the air current, as you can see in this picture. So a warm, draft-free environment. Usually, I've never been on a labor and delivery unit where there was like windows. I don't think so. But those windows are never going to be open because it's could be very detrimental to the baby. So keep doors closed as well, which I always see too. The doors are always closed. Um, and these are the effects I was talking about. If you are not following these precautions with the prevention, all of these, like you're not putting baby on mom, you're using a cold stethoscope on baby, you're placing baby near a cold window, this child is at risk for tachypnea, respiratory distress and hypoxia, hypoglycemia, and increased risk of jaundice. And these are all very life-threatening, right? We're talking about respiratory distress and hypoxia. So if you're not following these preventions, baby is at risk for this. Babies can lose their heat very fast. They're coming from an environment in the uterus where it was very warm for them and they were very comfortable, right? Brown fat is used for non-shivering. They're homogeneous to maintain body temperature. Meconium, stain fluid in neonatal resuscitation. Definition. So this is presence of meconium in amniotic fluid, common in post-term deliveries. So meconium is the first poop that of the babies. That's just a fancy word for like their first poop. It's very dark and smelly. So this is basically when there's meconium in their amniotic fluid. So this baby has passed their first poop when they're in the uterus, and that's not normally supposed to happen. So you have meconium, you have feces flowing around in the amniotic fluid. You can see why that is not safe and that can be very life-threatening. Feces is filled with bacteria. Um, Risk factors, fetal distress, post-term pregnancy, and oligohydramnios, which is low amniotic fluid. Interventions if the newborn is non-vigorous, poor tone, weak respiratory effort. Priority is to suction the mouth and nose before stimulating crying to prevent aspiration. Um, so yeah, this baby is going to come out and you're not going to see like a normal healthy baby. I mean, they were just flowing around in amniotic fluid that had feces in it. So what you're going to want to do, suction the mouth and nose before you are going to stimulate crying. All right, because we want to prevent aspiration. So think what aspiration is. It's basically when someone chokes and they get that in this case getting meconium into their lungs. We never want anything foreign, any fluid, definitely not any meconium, which is basically feces, into our lungs. All right, so suction, nose and mouth before you want that baby to cry because we don't want aspiration. We don't want anything in the lungs because then respiratory distress is going to happen, and that's going to be a much worser problem. All right. Assess respiratory function, obtain preductal and postductal oxygen saturation, assess with endotracheal intubation and deep suctioning if needed, because this baby is going to be in most likely respiratory distress. If newborn is vigorous where they're crying, standard newborn care, monitor for respiratory distress because they're at risk for respiratory distress, especially if they aspirate meconium. So you want to think when a woman water breaks, all that means that her amniotic fluid has leaked. So sometimes we can see amniotic fluid a different color. If it's darker, that's telling me that there's most likely meconium. This baby has had their first poop in the mom's uterus, which is not normal. All right. All right, so that's that. Omphalocele and gastrochrysis. Honestly, I've never been tested on this, so I've never really heard about this. So I'm not gonna go over it because I don't want to give any wrong information about it, but definitely just listen to what your professor has taught you about it. I've never heard of these, never saw any NCLEX questions on these, but whatever your this has been honestly never seen this on ATI either, but whatever your professor is telling you, stick to that. Jaundice and phototherapy is a big one. So there's different types. So you have physiologic jaundice, which is completely normal, appears after 24 hours and resolves in 7 days. So most babies get jaundice. It's usually just not alarming because a lot of babies have, well, every baby, they have they have an overproduction of red blood cells. Erythrocytes is another word for red blood cells, which you might see. So they have an overproduction of red blood cells, erythrocytes, and basically that causes a backup within the liver, so the liver won't be able to break down everything. So the system just gets a bit backed up. Jaundice is completely normal. A lot of babies get it, just because of how their system is. So yeah, it's only normal if it appears after 24 hours after they were being born, and it's usually resolved within 7 days. And we do want it resolved relatively fast because if you're not getting jaundice resolved relatively fast, that baby's at risk for kernicterus, which is when that jaundice, that bilirubin, travels to the brain, and then that can cause different mental problems later on in that child's life. Pathologic jaundice appears within 24 hours, which requires urgent treatment. That's not normal. You never want to be able to get jaundice within the first 24 hours of life. Phototherapy considerations: cover eyes with shields to protect from light exposure. So if you've ever seen it, you guys maybe have seen it in the mother-baby unit. Those eyes have to be covered. Monitor hydration. Increased stooling can lead to dehydration. The whole thing with the light therapy is that it wants that bilirubin to be pass through feces. So basically, the bilirubin is now unconjugated, and we want it to get to conjugated, and that's what the light therapy is doing, is trying to transform it from unconjugated to conjugated so that it can be now passed through feces. So that's what's happening. That baby just pooping out all this excessive bilirubin, and assess bilirubin levels frequently. I'm just gonna go to my notes from last year just because I feel like some of your notes that your professor gave was a little not too much information. So I'm just gonna find it real fast. I have it right here. All right. These notes are actually posted in a link that I shared. It's pinned in the notes chat. If anyone wants to pull that up. So if you just want to look at it, it's a lot of excessive information. I don't know how in depth teacher's going to go, but this is just a little bit more information. So because jaundice is a little bit complicated, and once you sort of just like get it down pat about like what's the patho behind it, it's a bit easier to understand how phototherapy works, how actually you need to treat jaundice. Hyperbilirubemia just means that there's a lot of bilirubin with circulating within that baby's blood. All right, so elevated total serum bilirubin levels. All that means is that there's elevated bilirubin levels within the blood. Jaundice is evidence with a serum bilirubin level greater than 5. So that blood level is greater than 5. Clinical significance based on age of neonate in hours. Like we just talked about, if it's less than 24 hours, that's alarming. After 24 hours, not so alarming, completely normal. Most babies get jaundice. And it also total serum bilirubin level. So if it's extremely high, that's alarming. Kernicterus, which I just covered a little bit, is abnormal accumulation of unconjugated bilirubin in brain cells. So the thing with unconjugated versus conjugated bilirubin is that unconjugated bilirubin cannot be passed through feces. Conjugated bilirubin is the one that can be passed through feces. So basically what our liver is doing, it's transforming unconjugated bilirubin to conjugated bilirubin. But if the liver is backed up because there's too many erythrocytes and all things like that, then it can't do its job the right way, and we're stuck with so much unconjugated bilirubin within our blood, so it can't be excreted because it's not conjugated. So basically the conjugated bilirubin sticks to this like layers of the skin, and that's when you see that yellow pigmentation. So basically if it gets super high and it crosses the blood-brain barrier, that bilirubin, and it basically attaches itself to brain cells. If it's too high in newborn and gets into brain tissue, it's toxic. It can cause deafness, delayed speech, poor speech, delayed motor skills, hypotonia, which just means poor muscle tone, intellectual deficits, things like that. Goal when we see hyperbilirubemia. Prevent this from happening, because if you're not treating it, it's just going to keep getting higher, higher, and higher, and then now it's going to affect the brain, which can cause all these things, which we don't want to happen. Prevent high levels of bilirubin in newborns' blood and body. Okay, that's your goal. Jaundice, bilirubin, and fat. How do you test it? You pull down the eye. You can see the yellowness and the sclera of the eye. Press in on the chest and release, and look at the blanching underneath. It will have a yellow hue. So this is basically just saying what we all know. Jaundice is really just that yellow pigmentation that we can see in the eyes and the skin. All right. Why does this happen? So this took me a while to understand, but it's not too bad. So when red blood cells are broken down, bilirubin is formed. Increased bilirubin levels are caused by physiologic jaundice due to infants' immature liver function. So babies are born with immature liver function. So jaundice is completely normal, usually, if it's physiologic. If it's pathologic, that's a problem. Where it's happening less than 24 hours, that's a problem. We never want this one happening. This can be due to ABO incompatibility. So maybe the father is type AB, and the mom is type O neg. That's incompatible with each other, those types of blood. So babies at increased risk for jaundice. If you think back to that mother having an Rh negative factor, and then that baby being Rh positive, that baby is also at increased risk for jaundice as well. If that mom didn't get that RhoGAM injection. Dehydration also increases risk of bilirubin because bilirubin is excreted via urine and stool. So the more babies eat when they have jaundice, the more they poop, the faster they get rid of bilirubin. So say a baby has jaundice, completely normal. It's happening after 24 hours. Liver is immature. It's not really able to basically make that bilirubin from unconjugated to conjugated because that liver's backed up, and it's super immature at the moment. What you're going to have to do, baby's going to go on light therapy. That light therapy is just trying to get that bilirubin from unconjugated to conjugated, because conjugated is bilirubin that can actually be passed through feces. So that's what we're doing with the light therapy. But that baby will go on some breaks during light therapy where they'll go and get breastfed. Breastfeeding causes that baby to, you feed that baby that they're going to want to defecate, and they're going to poop out all that bilirubin. All right, so feeding the baby and also the light therapy are the main treatments. My professor said last year, so major function of the liver is conjugation breakdown of bilirubin, which we need to happen. We need a functioning liver. Primary source of bilirubin is hemolysis of erythrocytes, so breaking down red blood cells. Bilirubin is released in an unconjugated form that is not soluble in water. Liver must change. This is basically the whole thing I'm saying. The liver must change unconjugated bilirubin to water-soluble form by a process called conjugation, conjugated or direct bilirubin. So if we have so much unconjugated bilirubin within the body, that's not good because it cannot be excreted. We need that liver to go from unconjugated to conjugated, and then the baby can poop out all that bilirubin. So conjugated bilirubin is not toxic to the body and can be excreted. So the whole thing I'm saying, unconjugated cannot be excreted. This is the bad bilirubin. All right, that's sticking to the skin, that's causing the yellow hue. All right, so it's the liver's job to change it. All right, unconjugated bilirubin is fat soluble and absorbed by sub-Q fat, which causes jaundice. All right, physiologic jaundice appeared. Okay, I think that is though that was just a little bit extra notes, just so you can understand the whole unconjugated conjugated thing. But just going back, because I had all the same things. Physiologic jaundice appears after 24 hours of age, first week of life. Completely normal, primarily due to increased red blood cell volume. Another word for that is polycythemia. All newborns have increased red blood cell volume because they needed those red blood cells to get oxygen when they were a fetus. So short red blood cell lifespan, they get old faster. Immature hepatic uptake, so the liver is immature. Also, delayed passage of meconium and bilirubin comes out in feces, right? So if bilirubin comes out in feces and this baby's not having their first poop yet, remember meconium is their first poop. So if they're not having their first poop yet, we have bilirubin just within the baby's body. All babies are prone to this. So completely normal. Blood test, total serum bilirubin typically peaks day 3 to 5 of life. So usually you're going to see that bilirubin 5 or more. Levels typically peak at 10. May or may not require phototherapy. Treatment, increasing frequency of eating. So like I said, like babies need to eat so that they can excrete that bilirubin. They usually eat every 2 to 3 hours. So they'll go on the light therapy. Then we'll be like, okay, take them to their mom. Mom's going to breastfeed them. And then we're going to put them back on the lights. More intake equals more output. Bilirubin then gets excreted. Concerns parents, but yeah, it does go away. Non-physiologic or pathologic jaundice is problematic. It's not normal to have it before 24 hours of age. So no newborn should develop jaundice less than 24 hours of age and always be treated with phototherapy. All right, so these babies do need to be treated with phototherapy. This one was like, maybe, but it just depends on the level. With the physiologic one, usually we just tell the mom to increase the feedings. Like you have to feed your baby every like 2 to 3 hours, so that baby can excrete that bilirubin. But this baby, it's more serious. So this baby needs to be on phototherapy after 24 hours of age. It tells us if we need to observe or treat. Our goal always is to prevent kernicterus. So we want to prevent that bilirubin from going to the brain, that unconjugated bilirubin going to the brain. Levels increase by greater than 5, and it increases rapidly. So an example would be 12 hours, that baby's 12 hours old and has a bilirubin level of 6, repeat in 12 hours, and then it's at 12. So it's pretty rapid, and we don't want it this high. Total serum bilirubin level is greater than 20. In term infant, usually is what we see with non-physiologic or pathologic jaundice. See how it says non-physiologic? Let's tell me that's not normal. It's not a normal part of life. Up here it says physiologic, normal part of life. Okay. Or was I causes? Like we said, RH incompatibility, ABO incompatibility. So like mom is type O, baby's AB or AB. Mom is RH negative, baby's RH positive. Preterm infant, liver is totally immature. And then we give packed red blood cells. Nursing actions, assess for risk factors, assess degree of jaundice, monitor labs. Usually going to see hemoglobin of level of high, red blood cell high, blood type and RH you want to look at. What is mom's RH factor? Direct Coombs, all of those results. Ensure adequate hydration status. Like we said, frequent feedings helps get rid of that bilirubin. So since this baby that has non-physiologic or pathologic jaundice, that baby's going to be on phototherapy, but also you tell the mom that they need to frequently feed their baby, breastfeed their baby. If she doesn't want to breastfeed, then we do the formula feeding. Implement phototherapy if ordered, always phototherapy. And this is just all the information with phototherapy. This is the decision to do phototherapy is the decision to do phototherapy just depends on the level of bilirubin and the age of neonate in hours. So is this infant 12 hours of age and they're having jaundice? Remember that's not normal. Exposure of the newborn to bright, high intensity lights to convert bilirubin into a form so it can cause more readily excreted in the stool and the urine. So remember that we want it to go from unconjugated, that bilirubin that cannot be excreted in feces, to that conjugated bilirubin that can be excreted out of the body through feces. That's the whole idea of it. So it does not change the reason for jaundice. It doesn't make the liver more mature. Does not change the blood type or RH factor. The whole purpose is to help the process of excretion. That's the whole thing. We're trying to get that bilirubin out of the body by transforming it into a type of bilirubin that can now be excreted. That's the whole idea of it. It's just a bank of fluorescent lights. You've probably seen on the mother baby unit. Phototherapy, nursing care 24/7 unless feeding until bilirubin goes down. So the baby's just going to be on it 24/7, but then, every 2 to 3 hours, that baby's going to go to mom, get fed by mom, then the baby's going to go back to the lights. Because it really is, can be life-threatening because we want those levels to go down, and we don't want that baby to get kernicterus where they're at risk for like motor delays, speech delays, deafness, things like that, because we don't want the bilirubin to go to the brain. So you want to get those levels down fast. So this baby's going to be on the lights like the whole day unless mom's feeding them. And this is all the education with it that's really important. This was like a lot of questions on my test last year. So cover the eyes and shield the genitals. So usually you're gonna, if you walk past a baby who's on these lights, the eyes are covered and they have a diaper on. Minimal clothing, so they're not gonna have clothing on. It's just a diaper and then eye patches. Maintain a neutral thermal environment, so assess temperature at least every 4 hours, because babies at risk for hyperthermia. They're under lights. Lights can be very warm, so assess them for hyperthermia. Provide optimal nutrition, so adequate, frequent, every 2 to 3 hours feedings to promote bilirubin excretion and prevent dehydration. Like I said, the lights help for to get it excreted, but the feeding does as well. Strict intake and output, stools, loose green and streaks of yellow, which may contain some bile. So it's just going to look like this is normal. Urine, dark in color, bile. All right. Need daily weights. You're going to weigh the diaper sometimes. It's hard to get daily weights on a baby, right? Because we can't really put a Foley in them where we can, really measure intake and output relatively well. We're weighing the diaper. Turn infant every 2 hours. This is important, okay? Turn infant every 2 hours. Don't want them in the same spot. Assess skin frequently. They're laying there for 24/7, but also they're under these lights, so they're at risk for like drying and cracking of the skin. No lotions. This always comes up, like even like on NCLEX questions. Don't ever put lotion on their skin, anything like that. Don't do it. Usually remove infant from lights for feedings, and bonding as allowed. So to bond with mom, but mainly we really need that baby to get fed so that that bilirubin can be excreted. Monitor that bilirubin level at least daily and sometimes every 8 hours. Depends on what level is and how many therapy lights they are under. Teach parents and bonding. If they want to visit their baby while they're under the lights, they can. And they have the little arm things where they can reach in. Turn off lights before blood draw. Discontinuation of therapy. Often have slight elevation of TSB, the bilirubin level after discontinuation of phototherapy. Rebound effect is completely normal, but we want it less than 10, greater than 10, no good. Usually if it's 10 or less, that baby can be discharged home. You tell that mom, feed your baby every 2 to 3 hours. So a lot of times babies can sleep like 16 hours a day, but you would want to tell the mom like, hey, like you have to feed your baby every 2 to 3 hours. That's going to help get the bilirubin excreted. All right, here are your newborn reflexes. These are important. They're always like NCLEX questions, ATI questions. So Moro reflex is just another word for a startle reflex. So it's sudden movement that causes the newborn to extend and then retract the arm. So they're going to extend their arms and then retract them back in. It's known as a startle reflex. So basically, usually to elicit this, you're going to clap and then you're going to see this happen. Rooting reflex. You're going to stroke the cheek of the baby, which causes the newborn to turn towards where your finger is. That's stroking the cheek, where they turn towards it. So maybe you've seen this mother baby unit. If you ever seen an assessment, the nurse do. It's pretty interesting. Babinski reflex is basically when you're stroking the sole of the foot, like with one of those, I forget what it's called, but like those little things that you use to elicit deep tendon reflexes, one of those things. You're going to stroke the sole of the foot, and that basically causes the toes to fan outward. So you're stroking here with like an instrument, and then this happens with the feet. They like fan outward. If you do this on an adult, that's not normal. That would tell me that there's something neurologically wrong with the patient. But in newborns, it's completely normal. It goes away as they age. But yeah, not normal in adults, but normal in babies. And that's your Babinski reflex. Stepping reflex is when you hold the newborn upright and they elicit stepping motions like that. Palmar grasp reflex is when you place an object in the newborn's palm and causes fingers to grasp. Usually, if you've ever done that on like mother baby unit, that baby is just gonna grab onto your finger. And it's always important to check for these reflexes because these are normal in babies. If a reflex is in here, that's telling me that there's something up with the baby, right? And these reflexes, they vary in when they go away. Like some are like they disappear in 3 months, some 6 months. It just depends. I don't think you guys would be tested on that. That's a bit like advanced. But usually you want them away by a certain time. That tells you that the baby's like maturing, right? Contraceptives. I'm not going to go into this just because I was never treated on it and I don't want to give any wrong information. All right, PKU is phenylketonuria. It's a rare autosomal recessive metabolic disorder where deficiency of PAH, which prevents the breakdown of phenylamine, which is like a protein, so leading to toxic accumulation and neuro impairment. Just gonna go with the clinical manifestations. Musty odor in urine and sweat, poor feeding, vomiting, irritability, microcephaly, which means small head, developmental delay seizures, hypopigmentation of skin, hair, and eyes due to melanin deficiency. All right, I'm not going to go too deep into it, but it's mainly just like the whole thing with it is like avoidance of high protein foods. All things like that. I honestly was never tested on this, so I'm not like too sure. but I know that they do a heel stick to test for this, but you can also test this when a woman is pregnant. But mainly we do a heel stick to check for all this if the baby has PKU, where they can't really tolerate high protein foods. All right, because it can cause a lot of different symptoms. But it was never really tested on this, so I don't want to tell you the wrong info. I'm just gonna move on. So congenital clubfoot is dysplasia of tissue, bones, muscles, ligaments, nerves, and blood supply below the knee. Can be unilateral or both. Like this one is both. And feet basically come in and are always below the nerve. So basically, these feet, they're not straight, right? They're inwards. They're going in. For some reason, we see it more in girls than boys, and usually tend to see it in breech babies, so babies who are laying horizontal. Diagnosis: prenatal ultrasound, a clinical exam. Management goal is to reduce or eliminate all components of that deformity that would result in a functional, structural, mobile, pain-free foot. Basically, the thing you want to do is to rotate that foot outward, right? So it's here we want to rotate that foot outward, which will go into the treatment. So the initial treatment is a serial casting method in which weekly we're going to gently stretch out and manipulate the misaligned bones, followed by application of a cast. So cast changed every 1 to 2 weeks, and then they get a new one. So it's a period of 6 weeks. So they're getting like cast, like 3 sets of cast, but maybe even 6 cast. Passive range of motion by parents after a cast off to keep muscles where they're supposed to be. Dennis Brown splints may be used. Rotate cuff outside, rotate more outward so they go out more, then back to normal. So this is the initial treatment. This is the casting method. There's this woman on TikTok, I think her name's Ken Craddock. Her baby was born with this, and he had to get casted every week for 6 weeks. So baby was born like this, put a cast on, and basically it's just trying to manipulate the foot to keep it turning outward. It's so inward. We want it to go outward now, right? So that's what the whole casting idea is. We're trying to manipulate that foot to stay in a normal position. And this is the Dennis Brown splints, where you're putting that baby in it, and basically you're just forcing that foot to just go outward, not inward. And if this is not working, the casting method or the Dennis Brown splints are not working, then we're going to want to do surgery. But casting usually works. The woman on TikTok who had the baby with this, he just did the casting, and he actually had this, but he went to sleep in these. After the casting was done, after the 6 weeks was done, then he was in the crib. He went to sleep with this on, and he's like perfectly fine now. So usually it works. These babies are cured, and they won't have any problems for the rest of their life. Nursing care, cast care important, weekly or bi-weekly cast changing. So if a baby's getting a cast, you want to think of neurovascular, right? Pulses, pain, think paresthesia, numbness, tingling, things like that, right? So we monitor for swelling, redness, which just means erythema, temperature changes. Elevate leg on pillow for a minimum of 24 hours above the heart. Parent education. You tell them that the baby needs a need for serial casting. So that baby needs casting for over 6 weeks to turn that foot outward. Keep cats clean. Sponge bath, because you don't want to submerge that baby in water with the cast on. Passive range of motion after casts are off. So it's all parent education. Parents need to comply, or else the baby's going to be stuck with feet like this, and they're not going to be able to walk right or hit any of those some motor, but like these type of motor, gross motor movements. Right? Developmental dysplasia of the hip. Head of femur is improperly seated in the acetabulum of the pelvis. So common risk factors: firstborn child, female, breech position, or low amniotic fluid in utero. Treatment goal is to maintain hip joint and reduction so femoral head and acetabulum can develop normally. So the femur, so think where that bone is, it's basically just not going into that like hole where it's supposed to be. So it's basically somewhere else. So that's why you're seeing those knee lengths are not the same height. One is like farther up than the other. Treatment goes to maintain hip joint and reduction, so femoral head can develop normally. Manifestations, so you have an Allisine unequal knee height, one higher than the other, because one, the femoral height is the femoral bone is going somewhere else. It's like not going into the socket. Sorry, I said hole, but I just mean socket. It's not going into the socket. It's going to the pseudobulum, which is just another word for like that hip bone. It's just going away from it. It's not going in the right way. So you see unequal knee height. You can also see a gluteal fold. So like folds of the gluteal. As you can see, like one cheek is higher than the other. And then ortonia or the Barlow test, you're basically manipulating the hips, and the hips click on exam where you can hear it and feel it. So that's what that is. As you can see, it's not in the socket. That head of the femur is not in, it's supposed to be in this socket right here, and it's not in the socket. So that's why you see it's uneven. This one's perfectly fine in the socket, this one's not. So that's why you see these differences. Gait abnormality. So obviously, yeah, the child's not going to walk the right way. Early diagnosis and treatment for maximum likelihood of successful outcome. Management, newborns and infants under 6 months of age. Pavlik harness is the first line treatment. It's mainly to maintain flexion. Remember, abduction is when you're going away, and external rotation to correct position. So this harness helps these babies, helps that head of the femur go into that socket. So all you're doing is manipulating the head of the femur in the right position, like I said. So it rotates the baby's legs out, pushing that femur into the acetabulum of the pelvis. And this harness is adjusted for the height of the baby. So we educate the parents, do not change, do not loosen any straps or anything. It is. And you have to wear it 24/7 unless, the orthopedic doctor says you can take it out. This is what it looks like. It's adjusted for that baby, and it's basically just trying to get that bone where it's supposed to be. After 6 months of age, it's not normal or anything. Surgery. Closed reduction, open reduction, or traction followed by a reduction to release muscles and tendons. That's just the surgery. I don't think you guys would be testing on that. I think I just saw on your blueprint was just the harness. I feel like it would be a good question if she asks about not adjusting the straps. I had a question on that last year, just like, and I think it was an ATI question too. Like, you tell those parents don't ever adjust those straps because it's adjusted for your baby specifically. And hip spica cast, this is what that is. And this is what they're going to be in after, if they had surgery. Sometimes this works, the harness just works. This is the cast for the baby, or if an adult had the surgery. This is the casting. It puts the hips into the same position. All right, nursing considerations. Pavlik harness, demonstrate care and application of harness. Teach parents how to put it on and off. Do not adjust straps. Where it is set is where it stays for that baby. Initially warn constantly, help them figure out how they are going to change their baby's diaper. Equal leg extension in and out of harness, because you don't want to change the straps. Clothes on under harness, cannot go on skin, just because you don't want to put a harness like this on a baby where, like, on their shoulders, and then skin breakdown happens. All right. You could do a skin assessment. Techniques. You want to teach the parents how they can hold their baby, feed their baby, and change the baby's diaper with this on, because this needs to be on 24/7. Because we really need to get that femur into that socket, because if not, that baby's at risk down the road for not being able to hit those motor milestones with walking. Spica cast is the full body cast here. Surgery post-op that's when they're wearing it. Monitor neurovascular status. With any cast, you're monitoring neurovascular status, so pain, paresthesia, pallor, all things like that. Supportive extremities, management of elimination, environmental stimulation, all things like that. Cleft lip palate. I went a little bit over. I'm just going to go over this just a bit faster so you guys have the information. Cleft lip and cleft palate are separate. Sometimes children can have both at the same time. Separate abnormalities are closely related. these are just really similar to one another because they're really similar in the patho behind it in nursing care. It could be, just cleft lip. It could be maybe the baby just has a cleft palate where there's basically a hole within the palate, which you can tell that's not good because now that baby's like like is exposed to their nasal airway, right? They're exposed to the airway. If there's a hole in the palate, the upper palate, or it could be a child that has both cleft lip and palate. It's not good. Abnormal openings in the lip or palate. We do have a hard palate. That's right. The first one, like you'll feel if you go to the roof of your mouth right now, you have a hard one, but if you go back a little bit more, it's soft. And it does develop in utero, usually like if moms are on drugs when they're pregnant, this baby's more prone to get like cleft lip or cleft palate unilaterally or bilaterally. The cleft lip is most often unilateral, so you'll see it unilaterally and may have happened on one side, but it can happen on both sides. Diagnosis, at birth where you can see it, or via OB sonogram. Depending on the child's position in utero, you can often see it on the sonogram, the lip one, especially at the 20-week sonogram that they do. If there's never any sonogram and a child is born, obviously a cleft lip is always obvious at the time of birth. Remember, this is something that happens in the first trimester of pregnancy at the time when all the organs are being formed. Palate, remember that's inside the mouth where your hard and soft palates are. So the cleft palate sometimes gives a delayed diagnosis until either the child's quick to breastfeed and you notice milk coming out of the nose, so that palate is not intact. So there's a hole in the palate, and our nose is right on top, right? So there's a hole there, then it's gonna be coming out of the nose, or maybe possibly that baby has milk going down into their lungs where they're aspirating. So not good. We want to get that fixed. Or they're in the nursing and we're doing a newborn assessment. Remember, mother baby nurses, they are going to sweep the roof of the mouth, and sometimes you're going to feel like an opening, and that is a sign of cleft palate. It could be either their typo, hard or soft palate, which is really bad. Okay. Management, severity of defect, and multidisciplinary approach. Management depends on if it's unilateral or if it is lip and palate. Not only the surgical team may impact dentition later in life when teeth come in, but it can also impact speech. So sometimes these babies, they have like lisp later on in life. A lot of practitioners are involved in this process. First intervention due to the risk of aspiration. Remember, aspiration is when a foreign body goes into the lungs. So if milk the baby's drinking goes into the lungs, which is common because, especially with this, there's an opening, right? It can go down into the airway because there's a hole that's leading to the airway. Priority is respiratory assessment on a child that has cleft palate because remember there's a hole that's, that's connected to the airway. Our nose is a part of the airway. Respiratory rate we check. You'll see tachypnea with aspiration, of course. Oxygen saturation decreases, and listening to their breath sounds. Maybe do you hear crackles if the baby aspirated? Things like that. Also have to think of elevating the child. Second priority, nutrition and hydration status. Is that baby just not feeding right? Is all that milk just coming out of the nose, going into the airway? Is it not going down the esophagus? That's what you need to pay attention to. Modify feeding techniques to allow adequate growth and prevent aspiration. Use of feeding techniques and unique nipples and bottles to decrease the energy required to take in adequate nutrition. So with these babies, you'll see an enlarged nipple like these. You see how big these nipples are. Stimulate suck. Make sure they have a good suck. Think about cleft lip. There's a potential for poor feeding, sucking, because they cannot come around that bottle. Like especially with cleft lip, like they can't come around that bottle and like really grasp it because there's a hole in their lip, right? So they're sucking in air and they're also sucking in formula because there's that hole. Swallow, make sure they're swallowing good. Give them breaks because they can get short of breath easily. And these bottles, you see how they're very long. Basically, if say the baby has cleft palate, what it's going to do, it's going to basically bypass the palate and go down their throat and go down their esophagus, which is we don't want to go down their trachea and their lungs. We want to go down their esophagus, right? So basically bypasses where that hole is within that palate, and it just goes down the esophagus. So these bottles are really great. tell the mom to give it to the baby at a 45-degree angle. So all that. Cleft lip repair by 3 months of age, cleft palate repair by 9 months. Like we said, concerns is respiratory, adequate fluid balance, risk for feeding difficulties, prone to ear infections, altered dentition. Okay, this is all just repeating itself. Pre-op, you always want to check nutrition. Are they gaining weight? Is there aspiration happening? Assess respirations prior to feedings, right? Are they becoming tachypenic when I'm feeding them? That's never a good sign. That's a sign of aspiration. Key into platelets, hemoglobin, hematocrit. That's what you do before all surgeries. You look into all your blood stuff, hydration status as well. All right, assessment post-op, positioning on their side or back. You ever want to leave them prone because you don't want any irritation to the front of their mouth. Assess respiratory status. Assess for redness, ecchymosis, edema, discharge, approximation. A lot of them will come back with U-shaped devices. The purpose of this Logan bar, that's what it's called, a Logan bar, is to keep the suture line intact, which it's doing here. And you want to put this baby in restraints, because if you don't, then they're going to be picking at where they just had that surgery, which is not good. So you're going to want those elbow restraints at bedside when that baby comes back. Nothing in mouth until cleared. And frequent burping, all right? Because these children are inhaling air a lot, especially like cleft lip, so you burp them frequently. A bit about neural tube defects. I think this is like the last. I'll just go through it a little faster. One bit over. Congenital abnormalities of the central nervous system. Remember, your central nervous system includes your central nervous system includes your brain and your spinal cord. So your neural tube, spine, and brain come together, and tube closes between 3rd and 4th week of gestation. Defect primarily affects spinal cord development. Remember, we tell women to take folic acid because that reduces the risk of all this happening from this happening. There's different types of spina bifida. So we have this one, which isn't that bad, spina bifida colta. Some people don't even know they have it. This one needs intervention, and this one needs intervention because we have fluid accumulating and we have a spinal problem here. This one is the worst one because you see the yellow here? This is nerves. These nerves are going here. So you have nerves involved. So it's harder to get, this surgery and get this closed up. All right. All right, so spina bifida colta, people don't even know they have it. Like you can see, it doesn't include nerves. As you can see, meningocele is a sac-like cyst, no nerve involvement. You see, no nerve involvement. It goes straight down. Myelonomycele is the worst one because it includes nerves, like I just said. All right, we place these babies prone because we don't want it to pop because it has nerves in it. The notes are here if you guys have it, but let me know if you guys have any questions. I think your thing had this one on it. It's a congenital malformation of the penis, but all the notes are here. Let me know if you guys have any questions. This is a review, fetal circulation. There's 3 shunts. Just know where the shunts are and like why they're important, right? These are how babies get oxygenated and get nutrients and all things like that. All right. These are the questions your professor posted. They're answered down here if you just want to read through it. I think I covered mainly the main things. But if anyone has any questions, please feel free to reach out. And have a good night.